a little bit of a different um, take on our Grub Clubs. We are calling this Couch Conversations. So if you would like, the active participation for today is this. Happy Healthcare Simulation Week. We love you all. If you wouldn't mind, we don't care what you look like. We don't care if you're eating. We don't care. Nobody's going to be staring at you, I promise. If you wouldn't mind, share your video. And feel free to put a cozy background on. And we're going to kind of relax. We'll give everybody a minute to do that, kind of relax, sit back. Imagine that we are on one of our beloved talk shows, probably not Jerry Springer. We could potentially go there. But I don't think anybody's within distance to kind of throw an elbow or throw a chair. So, please know that, we really appreciate you all. This is a great way for us to get to know one another, to share things and sprinkle in some best practice standards. So if you wouldn't mind, go ahead and turn your camera on. And, we don't care if you're multitasking, if you're sucking down some coffee or a meal, but it kind of helps us to create this nice environment of us being in the middle of a couch conversation. And, we are so thankful to, it's okay, Joel. We'll just imagine what you look like. But thank you for trying. We are calling this Couch Conversations. And so our guest for Couch Conversations is going to be Dawn Utz. We're going to talk to her in just a minute. I just want to let you know that this whole couch conversation is a spinoff of what our director section on SSH does on a regular basis, where they take questions from the audience. They talk about, some of the topics that are, up and coming, or maybe that are troubling directors around the world. And so today, our couch conversation is going to feature about getting started in simulation and how to grow in simulation while anchoring ourselves in some best practice standards. And so, again, happy Simulation Week. We're so thankful to have you all with us, to be surrounded by such a wonderful faculty and guests today. And so without that being said, we're going to go ahead and get started. So this is a little bit of a draft of our agenda. And in order to get us started, I'm going to kick this over to Dawn, who is welcoming fall, like myself. We are so happy for fall, and you'll see that as our theme of our background slides today.
Hello, everyone. Can you all hear me?
Yes.
Okay, perfect. Thank you guys so much for joining today. I'm happy to be with you all, and I have enjoyed every Grub Club that I have participated in thus far. And so I was very honored when I was asked, and very happy to be with you guys today. A fun fact, we are 3 days away from fall. I'm so excited about that because I love fall. I know many of you do as well. So being that we are 3 days away from fall, please everyone share what do you like most about fall? And it can be just one word. And we don't have to go in order. Just share what you like about fall.
I like the snow.
I'm getting chocolate chip muffins from Joe Beans.
Yes, Joe Beans.
Little
That's
shout
what I'm
out to
talking
Joe
about.
Beans.
Football.
Yes.
Cooler weather.
Mhm.
Halloween.
Yes. And
Decoration.
Going to the
Yeah.
orchard.
I know.
Seeing the leaves change.
Oh my gosh. Favorite. Yeah, I love those things too. They're so much fun. Speaking of Joe Beans, they do have really good, really good coffee and muffins, and I'm not promoting them, but I saw that they have another location coming soon. So anyway, certainly not promoting them at all. But when Hillary mentioned that, I was like, yeah, see it every day. And fall is a fun time. And I know children love to play in the leaves. And for us adults, it's a lot of work because we have to work to get those leaves up, but it's so beautiful It's just majestic, and so thankful and blessed to live in this area that we get to see these beautiful changes in our trees. So very happy about the change coming up and it being a little bit cooler. One of you guys shared that. Very happy about that.
So
So
Dawn,
thank you.
I want to share some responses for those of you that maybe can't see the chat. We've got apples. We've got pumpkin spiced lattes. I think we have a lot of coffee drinkers, by the way. So that Joe Beans tip might be really important that they're putting in one on Lakeside Drive. Colors, leaves, sweaters, cooler temperatures. I mean, I think you all like fall by this. Corey Trent says everything. And then, of course, one of my favorite responses, shooting turkeys.
Yes. Everybody likes a good turkey.
Yeah.
Thank you for sharing that, Heather.
Yeah, well, thank you guys so much for sharing fall. Fall is my favorite time of the year. I actually have scheduled PTO with nowhere to go except to be around and, kind of unwind. Fall for me is a great time of year because, I'm a forever student. And, I usually do my major planning in the fall. Like, what am I going to change? What am I going to try something new? And so if for those of you that are on this call, fall is a great time of the year for us to be a part of this. So we're going to allow our guests to introduce. So by a show of hands, how many of you know who Dawn is or have worked with her? You can raise your virtual hand or your physical hand on camera. See how many numbers we can get up here. We're at 11. Awesome. Okay, so out of those 11 people, keep your hand raised. Who wants to share a Dawn story before she introduces herself?
So funny.
I'll share. I first met Dawn when I worked as an OR attendant years ago when I was just right out of high school. And she worked in the prep room. And I tell you, she made me feel so comfortable being in a foreign place. And the laughs that I had, she took me under her wing and she was like a mama to me. I just love her and I'll never forget her for that.
Oh, thank you so much.
Aww.
That's so sweet. I appreciate that.
Yes, I actually have tears in my eyes. I'm such a sap. That's so awesome.
Aww.
Well, while we're on this, I think does anyone else want to share a Dawn story real quick, and then we'll actually let her introduce herself for those that don't know her.
Hey, it's Sarah Kurtz. I met Dawn also in the prep room, and she also worked in the PACU with me a little bbit. But my favorite moment was I was giving insulin, and I had a moment where I don't remember. I think I corrected myself and didn't actually give the wrong insulin. But either way, I was freaking out that I almost gave the wrong insulin and all this. And Dawn just talked me down off my ledge and kept me from freaking out and calmed me all down. And then she's also the one who brought me out to Bedford when she was the CQC out in Bedford. Brought me out there, so I cross-trained out in Bedford, and I fell in love with Bedford, and now I'm out in Bedford full time. So I love Dawn.
Oh, thank you so much, Sarah. I appreciate you sharing that. I don't remember that at all. I remember having you come out there out there to Bedford, but I don't remember the incident story. So I'm glad everything worked out. That's awesome. We all have those.
Made a big
those
impression
memories.
on me.
Oh, thank you. I appreciate you guys so much.
All right, Dawn. For those that don't know Dawn, go ahead, Dawn. Give us a little bit about you. Let us peek into your walls.
Okay. So for those of you that don't know me, my name is Dawn Oots, and when I go around to practices and introduce myself, I share with everyone that my name is Dawn, like the dish detergent, and my last name is UTZ, like the Utz potato chip. Easy to remember. But I love what I do. I'm an extreme extrovert, and I love people, which a lot of people don't like people, but I love people. So I am very happy to be here with you guys today. I have been with Centra for 30 years now, and I don't know where the time has gone because I feel like I just started yesterday. But the time has just flown by. And so I did go to school at Lynchburg General Hospital School of Nursing, and then later went back to Liberty to obtain my BSN. So very thankful for that opportunity. And I've worked in multiple locations throughout Centra, and most of those years were spent in the surgical arena with Sarah, and in different roles in the surgical arena. So I started out on the med surg floor and then went to recovery room. That led me to the Surgery Center of Lynchburg. All the while, I still maintained my position at Lynchburg General because I never want to lose that connection with Lynchburg General. I was just attached. I came back to work weekends. At that time, you could work 24 hours, but you were paid for 32. And so that was a great deal. I don't even know if they offer that now. I don't know if anyone knows or not, but I did that. And during that time, I filled in the prep room and worked in the prep room. Really liked that. I also worked a little bit in Sticky. I went out to Bedford for several years, and I was the shift manager of the outpatient surgery area, the recovery room, and the infusion center, and the pre-op testing area. So that was a lot of fun. Bedford is a great place to work. Enjoyed that. I left there and went to IT, and IT is you, as you guys know, we need IT every day. Every time I forget to include IT in something that we do, I am kicking myself because we need them with any change. IT was probably my least favorite just because I am such an extrovert. But I learned a lot and made a lot of great friends, and I'm thankful for the opportunity I was able to spend there at IT. And then I left there and went to accreditation licensure. So I'm very familiar with surveys and Joint Commission and CMS, very familiar with that. The two hospitals I served with accreditation licensure were Lynchburg General and then Southside Hospital. So I met a lot of wonderful team members through working in those locations with accreditation licensure. And then I moved on to come here within Centra Medical Group, and I work with the primary care offices and the urgent care offices, and then Lynchburg Family Residency. That's our, educational office there. And so I am all over the place from Farmville to Burkeville, Keysville area, all the way to Danville, and very, very happy to be here. So this has been a great opportunity to work with these team members in primary care. It's very different from working in the hospital setting, and I'm thankful for this opportunity. So thank you for having me.
Absolutely. We're so excited to have Dawn. If you haven't been to a Grub Club before or to Innovations, you would, whenever you attend those sessions with Dawn, and she asks such great questions, she's engaged, and she allows herself to be completely vulnerable about what work she's currently working on as a leader. And so we're just really looking forward to spending some time today, getting to know her a little bit. And so Dawn, our first question for you is, how were you first introduced to simulation? Was it in nursing school?
So I will share the story that when we first talked about this, it was the very first memory that came to mind. And while it may not have been at that time called simulation, it very much was that. And I remember it like it was yesterday because I was so scared. And I was in nursing school, and the instructors had paired us with another student, some who were a little more seasoned in the patient care arena, thank goodness. And we were to go into simple tasks. We were to go into a patient room, and we were to provide a bath and a bed change. How simple can that be, right? Well, I had never done that. And we talked about it in class. We went through all the steps, but when I crossed that threshold of that patient room, I literally began shaking, and I was so nervous. And the student that was with me had worked for many years in a long-term care facility. And she said, "Dawn, we've got this." I said, "Well, I'm glad you feel that way because I don't feel that way at all. I'm scared to death." She said, that's okay. She said, I'm going to get on the right side of the patient, and I want you to get on the left side. You get your basin of water, because back then we didn't have those patient cleansing wipes. There was no such thing. She said, I'll get my basin of water. I'll start washing the right side of the face. And then you do exactly what I do on the left-hand side. So that was definitely see it, do it. We really didn't have stimulation back then like we have today. And that was in 1991. Scared to death. All I was doing was giving a bath. How hard can that be? Terrified.
It is terrifying. Would anyone else like to share their first experience with simulation? Most of us on the call probably are, this isn't their first rodeo. We've been around the block. So simulation wasn't, like Dawn had said, a common practice. Maybe most of our first experience with simulation, we could tie it to CPR classes and those plastic mannequins and all that kind of stuff. But does anyone have a first simulation story that they want to share?
Hey, this is Sarah. I can share one. So I was trained in simulation. We had simulation in nursing school. So we had like a little room that you went in, to do your checkoffs and all that good stuff. So I understand that nervousness feeling because it was always stressful. So we had one simulation where it was something to do with like airway. You had to go in and figure out like the patient had taken his oxygen off or something and you had to put it back on. And that was like the whole simulation. It was very simple. So like I figured out the issue, fixed it, and like the patient, I guess, had like they, turned blue kind of around their mouth or whatever. And so like I'd fixed the problem, put the oxygen back on, and I go to leave the room and I'm like, oh, see you later, Mr. Smith. And then all of a sudden he starts like breathing really rapidly again and his face is turning or his lips are turning blue. And I was like, oh, okay, let me, so I'm like going to look to call like a code or something, or, cause I'm like, I guess that's the simulation. And I hear from behind the observation window, oh crap, I didn't mean to push that button. And so that was one of my first simulations as a nursing student. And so, they try to make it real life, but, thankfully my patient didn't die on me. So we were good.
Oh, that's fun. Thank you for sharing.
Yeah, thank you for sharing. So thankful for that, right, Sarah? Which makes you the expert that you are today. And so,
Exactly.
one of the things that Dawn mentioned was the see one, do one, teach one. Go ahead and raise your hand if you grew up in healthcare with the see one, do one, teach one methodology. Got a lot of people on this call that experienced that as well, and it doesn't mean that we're showing our age at all whatsoever. And so when we're looking at this, we want to anchor some of what we do in best practice principles. And I'm not sure if you haven't heard of these before or maybe just refamiliarize them with us, but Enaxel has published what are now known as the healthcare simulation standards of best practice. They have trademarked this, and they have individual standards that are in these areas. And so as you're getting started in simulation, there are things, listening to Dawn's story and Sarah's story, there are things that are in there that could help to help ourselves as facilitators and educators, and also help us to identify with learners on, how to do that pre-briefing. Dawn's pre-briefing was, hey, I'm going to be there. We're going to do this together. Sarah's pre-briefing was probably just a little bit different from that. And so sometimes, thinking about Sarah's story as simulation facilitators and educators, we need to build in during that pre-brief, if something happens that is unexpected or unanticipated, for them to know that, you as an educator can make a mistake too, and to be completely transparent and upfront about that. you'll see all of the standards that are listed here. So if you're not familiar with them, I would highly recommend, taking a look at them. They make sure when you look at them that they're the 2019 standards, because they did go through their second iteration of updating, but especially around the preparation and briefing, which was a new standard in 2019. These are great things for us to anchor ourselves in, and we're going to take a look at a couple of them today as we continue our couch conversation, but just kind of wanted to orient you to those standards and making sure that you can find those as a reference. So I think, Nicole, you get the next question.
Before I do that, Tiffany just shared that hers was with a doctor who wanted to see how well they could think on their feet. And they did some pediatric emergency like code blues. She said it was very intense and threatening and not a fun experience. So Tiffany, we're very sorry, but that does not sound fun at all. Hopefully your current peds experience simulation have not gone like that at all. But yes, so Miss Dawn, how did you get started in simulation?
So I want to ask this one question. Do you all, if for those of you who have been here a while, do you all remember the provider that worked and he was famous for, if he saw you were in the hospital and you were a student, he was famous for putting you on the spot and asking you questions? Does anyone know who that is? I see someone has their hand raised. Lori. I don't know if she's able to share or not. Is she putting it in the chat, Heather?
I don't see it yet. Hey, Lori, are you able to, is that a leftover hand from before, or would you want to comment on who this provider might be?
It was a leftover hand, but it might be Dr. Lockridge.
Dr. Lockridge and Dr. Giles. Yes, yes. Oh my gosh. If they saw you coming down the hallway and you, of course, back then we wore the nursing hats, their eyes were on you and they were already thinking of what they were going to ask you. And I feel probably some of the other ones on the call probably remember that. And I just remember seeing them and I would just my heart rate would go up because I knew that they were going to put me on the spot. So how did I get started in simulation? I did want to share this too. With CPR, of course, we always are taking part in CPR, renewing our BLS. And years ago, when we had to go do take our BLS class, it was not anything like what it is today. They would tell you to dress comfortably because your mannequin was on the floor and you would get down and you would do compressions on the floor. And so I feel like that many of you here today probably remember that, having the CPR training and you got down the floor and you did the hands-on, but that was stuck in my brain from back then, and it's very nice how it's performed now because we have chairs and we have the tables that our mannequins are placed on. But as far as getting started in simulation, I know working in the prep room, we would do more of like an in situ. We would have little areas set up where we would show the team how to put together an arterial line and have that set up, how we would do a triple setup, how we would run the iStat machine if we needed to, and how we would set up the cell saver and run the cell saver. Those things today are not done by nursing staff. Cell savers in the hospital, that skill is performed by a perfusionist. But back then, the nurses did that. And so we would have those little skill areas set up and we would work with teammates. And so it was hands-on, but sharing with them very much a simulation type of education on how we did those. And then we would give them opportunity to ask questions and then decide one up themselves if they wanted to, because there's nothing better than doing it yourself. So that was a great learning experience, and to be able to share with others and have that opportunity to be very transparent and ask questions, because we can't know it all. There's no way. That's why we have each other. And then when I came to work in Central Medical Group, Hillary Yates identified that there was a huge need for education surrounding medication administration. And Hillary, she put together different groups that would come to the sim lab, and we would go through all the steps, and we would share and learn together. And then we took that out to the practices. And that was a great opportunity, because when you go to the location where that employee works, they're more comfortable. They're also working with team members that they work with every day. And they could present to everyone else what they would typically do. The team could assess and provide feedback, but not in a way that was demeaning or hurtful, but in a way that supported that employee, because we don't always get it right, and we are human, and we have to show grace and realize that, oh, they missed a step, but maybe it was because this was in the way, or they didn't have this tool in that room. So that was a really great our educational opportunity for our teams within Central Medical Group to go through those steps. And I really appreciated Hillary bringing that to all of us, and being able to share that with each team member, and being able to take that to the offices too. So it was a great opportunity to share that medication administration with simulation. And I'll share this as well. In Central Medical Group, we don't have the barcode scanning. And so it's a totally a manual process. And so it's really important that you have a teammate and you look at things together and you verify with one another. So it's a little bit different from the acute care side. And so we really have to ensure that we support each other and have a questioning attitude, and keep our patients safe. So thank you, Nicole.
Hey, I'm going to kind of spin us over to Hillary. Hillary, are you able to talk to us right now? I'm not sure where you are in the world. I have a question for you, if you can hear me. She might not be. She was on camera earlier. I think she might have had to step away. But one of the things that Dawn was talking, I was thinking about, and it's this needs assessment, which is a very important step when we're designing our simulations. Is how do we find those gaps? For example, working with patient safety, who conduct RCAs, which are root cause analysis, their job is to put together a team to identify those gaps that caused either a delay or harm to a patient. And sometimes we need to incorporate that into, sorry, I have a bug in front of me. I'm not going crazy. Sometimes we need to look at our needs assessment to find out what the gap truly is, and ask some of those questions. Ask the 5 whys, like what, keep asking yourself, why does this happening? What's going on? What type of education have they received? When was it last, reviewed with them? And I know Nicole and Herman can speak to, when designing, our in situ simulations, a lot of the questions that they ask when meeting with the key stakeholders is, okay, how have you educated on this? What have they done before? Because sometimes, most often, simulation is not necessarily a great quote unquote teaching modality. It should be an experiential thing where they're actually taking that knowledge that they have and putting it into practice. And so, Dawn, I think you did a great job of talking about the educational need, and that that Hillary had uncovered, but taking that out into the practices now to make sure that for transferability, that while one group might struggle with it, there might be opportunity in other places. So
yeah, and Heather, a lot of the realization that we did have some issues, it was the reporting within the RL6 platform. And so having those reports that maybe a medication that was administered that had expired. And so Hillary identified those gaps, and that's really, we knew that if all the steps were taken, it wouldn't happen. So going through those steps and just reiterating and supporting our teams, not fussing, just supporting them. It's really important.
That's great information, Dawn. And it's always neat to kind of see things circle back, coming from CMG and seeing those things full circle. So I just love that you guys have done more simulation. You just can't get rid of me. Uh, but tell us about starting as a nurse and how simulation has supported you in your first clinical experience.
And I'm going to turn this, Nicole, I'm sorry, I'm going to turn this over to the team. If someone would share, because I know I shared my little story. If some others on the team, on the meeting today would share, what did they remember about their first simulation?
While you're working on putting your hand up and putting yourself out there, thinking about your thought, Tammy Thompson Pritchard put in the chat that we are seeing less medication errors within CMG now after this simulation, which props to the simulation. Yeah,
Yep.
we like
Yep.
to see that. We like to
Mhm.
hear that. So thank you, Tammy, for sharing that with us. Who would like to answer this question that's on the screen for us?
Because I know we've all had them. Every one of us on this team has had an experience. Even if it was just watching a nurse do something and then you went to do it and maybe didn't get all the steps right. And you say, wait a minute, show me that again.
Oh, we have Heather. Go ahead,
Yeah.
Heather Blevins.
So I went to LGH School of Nursing, and we had the one mannequin, in our like upstairs to kind of experience with, but I just remember getting to really kind of listen to like abnormal heart sounds and abnormal lung sounds on the mannequin that you didn't always get in the hospital environment when you were on clinicals, because you always seem to get the patients that were actually doing well and ready to be discharged, because that's just how it worked out. So, in simulation, it was great to kind of be able to really take my time and listen for like a full minute, where on a patient, they're like, what are you doing? Get your stethoscope off of me. Like, how much longer are you going to listen? So I enjoyed that in simulation. I got to really kind of take time and listen to those things, and then just kind of practicing like a head to body or head to toe assessment, and just getting to really kind of do that and feel comfortable with it not being a real person that would be looking at me like, what is taking you so long? So
Right. Great example. Great example. And I can remember thinking when I walked into a patient's room that as a student, thinking to myself, because I was so new and scared to death, I was thankful for the patients in the very, very beginning that were not as coherent to really know what I was doing, because I felt very inferior and intimidated. And I thought, well, they're going to know if I do something wrong. They're going to pick up on the fact that I'm nervous and my hands are sweating. So nowadays, I don't want anybody that's out of, that's maybe not intact. I love to talk with my patients. And so it's funny how I felt back then, because I was just so scared and wanted my patients to be a little bit out of it, so they wouldn't notice if maybe I missed, a quadrant on the bowel sounds, which is kind of crazy. Does anyone else have a story they can share?
Paula, are you willing to share your story that you put in the chat and talk a little bit about that? I'm not sure if you can speak right now, but I see your pretty face, so I'm hoping you can.
I can. When I was getting my master's degree, one of the clinical experiences I had was working at a simulation center. And it was just so awesome because they had everything there. They had the talking patients, they had what else did they have? I don't know. They just had everything. And she let me do some actual simulations, which was kind of cool. I get to write it up and implement it. One of the things that I thought was really cool was they were teaching the residents how to act when they made a mistake and how to approach the patients. And they would have a whole simulation set up for the residents to go in and talk and practice doing this, because of course it's not an easy thing. But it was awesome.
That's wonderful.
It
Any
is.
of our academic faculty on the line want to talk about maybe a story on what you've taught them in simulation, that you maybe heard a story back in regards to when they went to their clinical experiences, how it prepared them? I don't want to put anybody on the spot, but maybe somebody from our academic perspective on this. Anybody?
Well, hi, this is Valerie.
Yeah,
I guess I can speak on it. I
sure.
was first introduced to simulation when I was in nursing school, and during our capstone, we certainly had to do a simulation in order to pass the class. And I remember mine was inserting the Foley. So I was real nervous about it. I didn't know what to expect, but I do think as I felt it was a safe way for me to learn and just practice the skill without real world risk. So that was able to make me feel a little more comfortable, and I knew what to expect if I really had to go out and do it. And it helped me to visualize and just understand um, just what was expected and what was expected for me to do in a situation if I had to insert a Foley. So I think it's just it helped me to improve my performance in like real life situation.
That's awesome. That's awesome that you can share that experience. I mean, I can share the antithesis of that experience because when I went to school to be an athletic trainer, taking care of healthy patients. When I became an ER tech, one of my responsibilities was putting in a Foley catheter, and I still am probably a little bit naive but back then I really was not excited about the male catheter situation. And so I would try to pass that off to other people as long as I could. And, but at the end of the day, I would not let a patient, wait. So I remember my very first one did not go as well because I did not understand the whole prostate. And I'll never forget, Brenda Mull was my nurse on that shift. And she came over and she talked me through it. And I'm like, felt embarrassed for the gentleman that had to endure some bleeding and some pain because I wasn't educated. I just was taught verbally taught. I watched one and then I did one. That's basically how they taught us. So having gone through on the other aspect of it, Valerie, simulation helps a whole lot. And something with a task like that, there's a lot of things you have to consider, like where do you put your stuff? Where do you put your hands? How do you maintain that sterile field? And, it's just so interesting, how far we've come in preparing, whether it's a student or practicing clinicians like Paula had shared. It's just such a wonderful modality that, I fell in love with that aspect of not having to, endure the embarrassment of, not really knowing what you're doing. So Dawn, our next question for you is to tell us about your simulation experience. This is a wide open door for you, so you can talk about whatever you want to talk about.
Okay. So recently we have, and Valerie Nash, I know that you're very aware of this as well. So please chime in. We have really partnered with Nicole and with Herman within the simulation lab to bring the mock codes to our practices and work with our teams and go through all the steps and have those simulations. And it's fantastic because Nicole and Herman, they will set up the scene or the educational opportunity by sharing with the team what we're going to do and what our goal is to put everyone kind of at ease, because some people, when you mention that we're going to do a mock code, they become very anxious, nervous, because we don't ever want a patient to pass away on us. And what if we mess up? What if we do the wrong thing? Will others think poorly of me? So it comes with a lot of pressure, and staff members feeling like they've got to perform and they've got to perform perfectly. And while we want our staff to be confident, we also need to support them. And so Nicole and Herman have done a wonderful job in joining our teams, coming to the practices and getting them set up for the mock codes and going through that with them. We have done this at several locations, and more locations are scheduled. And so we have learned, and we've been able to share some of the things that I do want to point out is you don't know what you don't know. You don't know. So if you've never done it, you don't know. So we've learned that we did not have some of the things that we needed to, if the event occurred, to support the whole process. One of the locations, we did not have a backboard. Probably no one ever thought about it, but we didn't. We also did not have all of the size and boo bags that practice would have needed. So doing those mock codes, we realized these things and we were able to learn, oh, well, we need this. Oh, well, we need that. And we also learned that where we keep our medication box, everyone needs to be able to get to that medication box, not because they need to give medicines out of it, but because maybe they are a runner. Maybe the nurse or the doctor who's responded said, hey, Jane, go get me the medication box. Well, if the medication box is locked in a room that Jane's badge won't unlock, we have failed the patient, not meaning to. We just didn't have that scenario or that simulation prior to this or the event occur to realize, because we thought we were keeping it safe by keeping in that room. So we came up with a different plan. We also learned that um, the um, the locations in some of our offices are very hard because at the end of the hall, so it's very hard to hear. And in the late afternoons when staff levels have gone down, sometimes you still have a patient there you're providing care for, and if that event should occur, how do we let that provider or that front office staff member know that you're having problems with this patient? So we've been working through some of those issues with trying to get form of communication. And then also locations of defibrillators. We've learned that some of the locations we have the defibrillators did not best serve us. So we have ordered the boxes, the metal boxes that hang on the wall, and we're going to reposition those within the clinics. That's just some of the things in one location, we didn't have the paper documentation form. But again, we hadn't been through the simulation, so we didn't realize that. We thought we were prepared. And that's okay, because that's what simulation is all about, is realizing, oh, I don't have this. Okay, well, what do I need to do to get that? And who can support me? And so getting those things in place, making those changes, reaching out to people, and then after some time goes by, having that simulation again. And I hope that Nicole and Herman will come back and go through these steps with us again, because we learned a lot and we were able to share. And so one of the simulations, we realized that nobody was recording anything. So just those things, which you don't maybe immediately think of until after you get into, you're like, oh, wait a minute, no one's writing anything down. But that was a great experience and an opportunity to support each other. And so it's been great. Been great. So thank you, Nicole. Thank you, Heather.
You're welcome.
And Herman.
Has anyone else had an experience where, I saw that Tiffany kid, you said you don't know what you don't know. And when you make an assumption, when you do a simulation, sometimes you find yourself, whether it's academic or if it's clinical location, sometimes you end up finding things that you never thought were an issue. I know, speaking with Dawn and working through some of these action items with her, she has a great system of, what supplies are needed. She's got lists, she's got checklists, she's got all of this stuff, but she's finding that in some of the locations, not everybody knows about the list. Not everybody knows what is supposed to be included. And, talking about the location of defibrillators, gosh, that would preach a whole session, in making sure that you have equipment and everybody knows where it is and it's easy to get to. And so does anybody want to share anything from their experience along that line of, uncovering things that you didn't anticipate while doing sim?
I know you guys have got some stories. Don't be scared to share. Everyone's being very quiet. They don't want to share their experiences.
I'm sure they do. Someone wants to.
It's okay. A lot of times people don't want to share things that maybe didn't go well, and that's okay.
You know, and that's one of the things I think that's wonderful about simulation. I'll never forget when I worked at a medical school. It was a startup medical school, and we were doing simulations, and we wanted to integrate it into the curriculum. Which, for those of you if you have any experience in medical schools, it's not a normal thing. They're used to standardized patients and all that kind of stuff. And I'll never forget coming out of a whole entire day of simulations feeling so defeated because I didn't know what they were taught. And so there was a lot of assumptions made by faculty members that didn't know what was going on within the curriculum. And so there was this assumption made that it was going to be something that they were prepared for, and they were clearly not prepared. And, you know, I'm going to go backwards in time for just a second here. One of the things that we stress so highly within our program, and while we're so thankful for all of you that are on this call and engaged today, is this professional development. That mentality of see one, do one, teach one does not apply to simulation. You should be taught and trained on how to develop, implement, deploy, evaluate simulation. And so the best practice standard that we're looking at here is this professional development. This was new. This was added in 2019, where you're conducting your own needs assessment. What do I need as a sim facilitator or debriefer or an operator? And actively participate in your development, seeking out ways to, you know, to kind of shore up those gaps within yourself and to reevaluate yourself after you have put together a plan and say, did this work? Is this helpful? And this is a part of our ongoing professional development that we'll be probably rolling out in the next year is, you know, looking at how do we do our own self-assessment and identify our needs as simulation faculty in order to make sure that we're getting what we need. It's the reason why we do needs assessment for Grub Club. If you complete the survey, you're providing us a needs assessment for what we use our next Grub Clubs were based off of those. And so really what you were talking about is how do we, you know, develop ourselves in simulation, just like we did clinically. You know, how did we, you know, do that for our learners? We have to also do that for ourselves.
And Heather, I'm going to tap into that as well, as far as, you know, developing and learning. When going to our offices, one office in particular, their clinical, their providers were jumping at being in that room and sharing what they knew and moving forward and talking all through it. While another one of our offices was very much the opposite. They did not have the providers really jump in. And so I did go to each provider and share that we were going to go through the simulation again, and they were welcome to join. We did not want them to miss out. And they did not tap into the opportunity. I feel, and I may be wrong, our providers, while we work with them day in and day out, they may be just as uncomfortable at being put on the spot and knowing all the steps, because maybe throughout their career, they've not seen a whole lot of it either. And so it's an opportunity for them, whether they're a provider, whether they are the person up front that answers the phone, or the person in the lab, or a nurse, doesn't matter. We just need to encourage our entire team to jump in and take part in the simulation, because it does matter. And we look to our providers a lot for answers, but that doesn't necessarily mean they're comfortable in those arenas either. Mm-hmm. And we have to, you know, realize that. And I do understand that, but we do like to have participation of everyone. But that was just interesting, and just a difference in locations.
Sure. Would anyone like to share a story, whether it's, you know, your own professional development as a simulation faculty member, or maybe identifying an opportunity like Dawn had suggested with buy-in, getting engagement of particular staff members or maybe even students. Would anybody feel comfortable to share a quick story on that before we move on?
It's Sarah again. But
Sarah.
I know when you and I kind of started some of the simulation program for Lynchburg General, that took a long time to kind of get people on board with like the big simulation, not just like we had done drills and we had done like kind of practice things, but making it a very formal simulation. What took a while to get people on board with like, no, you're going to go through like the whole thing just like you would. You're not going to stop and, just act it all out. We have all the equipment for you. And getting the providers invested, I think took some time, especially anesthesia, because they're so crucial to like our codes and to, especially in the OR, to anything,
Yes.
anesthesia is running it. So it doesn't really help to have one of us do it because we need anesthesia there because they're the ones who are ultimately going to do it. And so getting their buy-in was really big. And I think, it took some time. It took a couple simulations to kind of like pull them in. But some of the younger providers shared with me that they were familiar with simulation because some of the schools you're doing simulation as doctors now while they're in medical school, and they're even doing some cross discipline simulations with like nursing and other specialties, which is really cool. So
Yes.
the younger generation of doctors, I think, are more comfortable with simulation and more familiar with it. So sometimes if you can start with them and kind of tap them to help you, I think you can maybe rope in some of the other providers, but it definitely was a
Exactly.
challenge.
It's
That's
such
so
a
true.
And I just want to report back that we have, correct me if I'm wrong, Herman and Nicole, every single simulation that happens in the OR, for the most part, sometimes on the evening shift, they have lesser numbers. We have active participants from anesthesia. Sometimes we have more than one. And so, sometimes you don't get to just to stay around to see the fruits of your labor, but we can attest that that work is not in vain, and sometimes it takes time for change, to see change. And so just wanted to give you a little shout out, Sarah, of that hard work is definitely, we're reaping the benefits of that today. Nicole, you want to transition us to the last discussion point? It's on
Sure.
the screen. Thank you.
Yeah. So, Miss Dawn, can you tell us what some of your priorities are for your clinics in regards to simulation and like why you want to keep going?
Absolutely. So simulation does provide that framework for each office to be able to lean on and confidently move forward with the right steps when an event should occur. And really, it's being able, from no matter what angle you are in that office, that you can support the team. So maybe you're not the person that is comfortable doing the compressions, but you don't mind calling 911, or you don't mind bringing the medication box, but feeling comfortable in how you can support that situation, providing that framework. And also, we talked about assigning roles, Nicole, to the team members, maybe to have it a month at a time, that if an event should occur, this is going to be your role, this will be your role, and having that type of pre-designated assignment for our team members. It also allows us to assess our barriers and look at our opportunities. And while we have, with the simulation mock codes, we have done that, we have learned a great deal, and we are making changes. That doesn't mean one and done, because staff, they change. They leave, they come, and we need to be able to support them. And situations can occur no matter where you are. They can occur in the office, they can occur in the parking lot. And to be able to best support our teams when these situations occur is really the foundation. if we can do this, if we can keep moving forward and practicing and putting those solid steps in place, we are going to see better outcomes for our patients when these situations do occur. And it's important. And so we are going to push very hard to do this in all of our clinics. I talked with our director yesterday about it. So we just appreciate the partnership that you all have offered us in the simulation lab, because I don't feel we would be nearly as successful without you. So I'm just so appreciative of each one of you. Thank you very much.
Oh, you are absolutely welcome. And one of the things that Dawn was highlighting was looking at the outcomes. When we're designing our activities, looking at the end, what do we hope to accomplish out of this? And it's okay for simulation, depending upon where you find yourself, for it to be identify opportunities, identify gaps within your system of care, like she was explaining, and really creating a culture where we're not afraid to talk about the mistakes we make. That's one thing that I feel like, looking at healthcare from a broad perspective, that sometimes a novice caregiver is afraid to admit that they've made a mistake. They want to hide it, or they want to explain it away. But how can we have, maybe a crucial conversation, or be able to create a culture where we're comfortable giving and receiving feedback, that, our ultimate goal and our ultimate outcome is improving patient care, uh, safe care delivery, effective care delivery, and so that goes foundationally into what we do as simulationists. If you haven't heard that term before, everybody on the line could add this title to them. You are a simulationist. What a better way to celebrate the week than celebrating our work as simulationists. But looking at, those outcomes, determining how we're going to evaluate what those outcomes are, and what are we going to do. Dawn mentioned multiple plans that she had to put into place to make sure that her caregivers at the CMG clinics have what they need, have those resources, identify their roles and responsibilities. Because, some of us that work within, like, the hospital are used to being trained in things like CPR. Not everyone is naturally trained at in a clinic level in CPR, and so they might not be comfortable in giving chest compressions. And she's done her and others at other CMG practices are being connected with CPR resources, because as a Centra employee, they're given an opportunity to take those courses to help them, to be better at their response to this very, low volume but high risk situation. And so, there are standards around best practice on how we determine what those outcomes are. How do we measure our objectives and things like that? And that's just kind of grounding us a little bit in best practice measures. And I know that we're out of time. We didn't get to cover everything today, but just wanted to take a minute here and to thank Dawn, first of all, for being our first guest on our couch conversation, but also to kind of ask the audience really quick, is this something that's helpful for you to be able to talk about some of this and maybe ask questions? We'll work on the asking questions part a little bit in the future, but anyone else want to kind of just give us some just-in-time feedback? You won't hurt our feelings. We just want to know if this is something that's helpful in the future.
Do you guys feel comfortable with this format of being kind of laid back and being able to talk about things openly and share? Okay, got a thumbs up. And I will say another grounding comment, Heather, if we do things right every time, we don't learn. So learning is a part of, making mistakes is a part of learning. We don't mean to make mistakes, but we grow because of them.
Mm-hmm.
And it might hurt, but it only hurts for a minute. And then we grow,
Yeah.
Yeah.
Thank you, Dawn, and thank you for that perspective. Thank you all for those that gave hearts, gave us a thumbs up. We'll try to do this maybe, once in a while to kind of break things up a little bit. And maybe, next time we'll ask you guys to pepper some questions for our couch conversation. Maybe we'll put Joanna in Dawn's position and let her be the couch person to answer some questions. It is our heart's desire that you have what you need as a simulationist. And we are so thankful, so grateful to have Dawn share with us and take the time to prepare to share with us. We are so grateful for each one of you. Anyone, if you have any feedback, go ahead and put it in the chat. And we wish you a very happy healthcare simulation week. And please make sure you stop by and get some goodies from our simulation center.
Thank you, Heather and team. You guys have a great rest of your day.